Welcome back to Design to Thrive. We have another episode with an amazing guest, Mr. Michael Leibman from IPQ Analytics. Welcome, Michael.
Thank you. Glad to be here.
Awesome. So we'll dive deep in. What inspired you to establish IPQ Analytics back in 2011?
I have a mixed background of academics and pharma and diagnostics, and I also ran a breast cancer center for the Department of Defense jointly with Walter Reed. And was a bit concerned because I kept seeing a number of questions and issues that weren't actually being addressed in the traditional sense. Understanding what disease really is was a challenge, and yet we developed drugs without that comprehensive knowledge and understanding. We develop diagnostics and try to fit it into our limited understanding of what disease is. And so I thought we had an opportunity to explore the fundamentals of how do we define disease? Can we improve the decision making and tools that a physician has at hand and have a much more positive impact on patient outcome? And that's what led us to create IPQ Analytics.
Okay. So can you share a pivotal moment that significantly influenced IPQ's direction?
Well, I worked on the original HER2/neu test before there was a drug. It was a first genetically linked test. But what I found out is, as the test was being developed, it was being developed based on the available technology and some indications without actually understanding what the disease was. And that lack of understanding the disease basically set in motion in me a drive to really try to see what can we do to understand disease better than we do now.
And Michael, is there a particular quote or philosophy that drives your approach to innovation?
Well, there's two quotes that I go. One is from someone else, Edward Deming, who is an economist, and that quote is, "If you don't know what the question is, you'll never find the right answer." And that really means you have to focus on identifying what the problem is before you try to solve it. The other is one that I use that I made up, which is technology is the instantiation of the solutions to yesterday's problems, but doesn't know what today's problems actually are. So they're related, but a bit different in flavor.
Okay. So how would you describe IPQ Analytics model as a service approach?
But what we're trying to do is look at what are the unknown unknowns in clinical practice, in understanding disease, how that translates to patient care, and also translates into drug development, diagnostics, reimbursement, and other areas. What we're building are models of the disease, recognizing that disease is a process, not a state. So it evolves over time. And what that really means is a patient who may come in at different points in time in their disease may actually get diagnosed differently and be treated differently rather than understanding it's a different stage of the disease. And that is something critical that needs to be developed in a much more robust manner for many, many diseases, especially complex disorders, not just looking at genomic information but understanding what all the interactions are of environment and lifestyle, clinical history, and things of that nature that interact with that person's development and may lead to disease. And so, what we're really focused on as a model is the disease process and recognizing that disease is a process and not a state.
Could you elaborate on how your hybrid human machine knowledge graph functions?
Yeah, knowledge graphs are what I consider to a certain extent an evolution out of what we used to call object oriented representations or object oriented programming efforts. What they're looking at are the relationships between many, many concepts. So it's not a row and column type of approach, but many to many kinds of interactions. Right now, most knowledge graphs are focused on taking things like a number of different data sources, they may be databases, linking the ontologies, finding out where something is referenced in multiple databases, and being able to tie that together in the knowledge graph so you can very rapidly find out where information exists and what may be related to it. The challenge that we're trying to overcome is that's taking advantage and its critical value in taking the knowledge that we already have. But the knowledge that we already have is not adequate. We have many gaps in how we diagnose and treat disease or develop drugs. So that tells us that there's a lot of unknowns. And what we do is we're trying to take advantage of the knowledge graphs that have been developed by very large teams because they're excellent products, but they don't convert into that unknown space that would enable them to be what we would call actionable on the clinical level. So they're very good at representing and serving the questions that someone may ask of it, either from research or clinical domain, but they don't necessarily address the questions that a clinician or researcher should ask, really interface with the questions they are currently asking. And what we're trying to do is drive beyond that. So when we work with clinicians, we're trying to identify, again, those unknown unknowns and look at the root cause problems that may exist or issues, and then deconvolute that and create the concepts and relationships necessary to address those complex questions. That's what we build into our knowledge graph on top of the other knowledge graphs.
Awesome. So, how does IPQ address the evolving nature of diseases over time and its models?
Well, that's exactly what we're able to do because we can, with a temporal component that we've added, we can look at the fact that a disease may be defined differently at different points in time. It could be something as simple that we don't even consider when we talk about something like inheriting a disease and we ask about family history. We may ask, did your mother have breast cancer? Did your grandmother have breast cancer? But what we really should be understanding is that when they were diagnosed with different guidelines. They were diagnosed with different diagnostic tools, and their breast cancers may not be the same. And that's more very important to understand, not just that they had breast cancer, but what subtype of breast cancer they had, because that doesn't automatically mean that they've inherited the same type of cancer. And we need that kind of granularity to be able to really understand the complexity when we're trying to extract knowledge out of all the data, not just have a lot of data.
So, what prompted IPQ to emphasize on women's health, particularly around menopause and breast cancer?
Well, when I ran the breast cancer center for the Department of Defense was the time when BRCA1 was becoming a very hot topic and genetically linked breast cancers. The challenge was because I do systems modeling, even though I'm a theoretical chemist. When I looked at the system, I said, out of all the breast cancers, only about 10% are defined as genetically linked. 90% of them are occurring perimenopausal or postmenopausal, but we don't understand menopause. And anecdotally, we know women go through menopause differently, but we really don't have any information to know what that impact may be. And so over the years, we started building simulation models of how women undergo menstrual cycles and then how that evolves over time into menopause. But now what we're doing is trying to actually use patient data that doesn't currently exist and build models of how women go through this as individuals. And what that means is because it's not well defined perimenopause and menopause in terms of training in medical school, they rely much more on their friends than what they're getting from clinical advice. When they rely on their friends, what they're not able to understand or acknowledge or be able to deal with is that in 80% of all women, 100% of all women effectively go through menopause. 80% of them will have hot flashes. And one of the first things you may ask your friend about is their hot flashes. But what you're not recognizing is your hot flashes and their hot flashes may not be the same. because there's a lot of other symptoms and other presentation that may be interacting with their hot flashes or producing it in a different sequence of events. And that's critical for knowing how similar they are and if what they're able to respond to treat that is going to work for you. And so that's the kind of information that we need. But it also points to the fact that in women's health, the data doesn't exist. So one of the things we've done, what we try to do is we try to not take the data that's available and apply AI and ML to extract unknown patterns. We think that's very valuable, but it's limited to the data that's available. What we're doing is building models independent of the data, as I described with that knowledge graph uh, description. And with that, look to see what data exists and what data doesn't exist. When it doesn't exist, now we're actually collecting the data. We have two studies going, one in the US and one in Australia, that are actively collecting data so that we can enhance the models going forward.
Okay. Can you walk us through your two-phase model building process with clients?
Yeah, what typically happens, and this comes from when we were not talking about the nonprofit work, but just our general approach, the models as a service. We have been called into a number of different groups, whether it's a pharma or biotech group, or it's a payer group, or it's a healthcare provider group, or even a government agency or an investment bank. Typically called in because someone has a question and they would like to have us try to address it. Well, the very first thing that we do, why I say it's two phases, is we sit down and try to figure out if that's the actual question that needs to be addressed, or is that the question that is on the surface? A physician typically, when they ask you a question, it's because they're operational and they need to get that information to be able to treat the patient who's coming in the door to their office in 30 minutes. But that may not be the actual question that needs to be addressed. And an example of that would be, I need to know something about this test or this new drug and if it'll be suitable. And the question we really will start to address is, how confident are you in the ability to actually make the right diagnosis for this patient, the subtype of disease, to stage the patient where they are in the disease, and how rapidly they're progressing? And are these going to be important factors, as well as what other things, comorbidities and polypharmacy, really need to be considered, not just the focus on the disease itself? And so that's what we call the first phase of what we do. We then digest that, and come back with the second phase, which is, these are the factors that need to be considered. We don't know if all the data is available. If it's not available, either we can collect it or we can at least be transparent and say, these will be constraints on what you can do in the analysis or what the model can predict. And if it doesn't work, we have an idea of what's missing. And that's what we mean by two phases in our studies.
Okay. And you mentioned AI and machine learning before in the conversation. Is AI and machine learning a key component of your work?
It's not, it's one of the tools we will use, but we're much more focused on identifying the problem and then what is the correct tool to apply. AI and ML are very powerful, and you would associate that with the big data collections that we have, and we have a lot of data. But you also have to understand that what they are able to do is identify patterns that exist in that data that you may not see very readily. And that's the strength of what they're able to produce. But the data that you've collected inherently has been collected because it's based on some model that you conceived of. That's why you collected that data. And so what you're actually doing is assessing patterns that exist from that model. You're not having an open ended exploration of the whole space. That's why we talk about the difference between data driven modeling, which is the AI ML approach, and what we call model driven data, where, as I said before, we build a complex model independent of whether the data exists. and then look to see if the data exists. At the same time, what we're also doing is trying to understand, as I pointed out earlier, what's the question that needs to be solved? Is it simply identifying a pattern? Is AI and ML the tool we want to use for that? Do we have to do other types of modeling with simulation? Are we applying graph analytics? A variety of other tools that we've developed and acquired over time. And, sometimes what we find is the tools don't exist or haven't been developed in life sciences. And what we do in those instances is we'll look at the problem, define the generalized characteristics of the problem, and then go to different disciplines where problems of those characteristics exist and borrow the tools they've developed to actually apply them, adapt them, and apply them in the life sciences. And we've done that on a number of occasions, and that's led us to build tools that can simulate pathway behavior, reason about pathway behavior, not just simulate pathway behavior, things of that nature. But those tools came from communication engineering, where we took tools that were used to develop cell tower networks and adapted it to what we wanted to do in biology. So that's why I say we're not an AI ML company. We don't come in looking for problems to apply AI and ML. We come in to identify problems and then figure out what the right approach is to address them.
Okay, so how does IPQ engage with international healthcare systems to enhance data collection analysis?
Well, there's a couple of ways. One is we're very interested in addressing disparities in underserved population groups. So when we're looking in, as an example, we've discussed the menopause very briefly. We're also looking at things like preeclampsia and hypertensive disorders of pregnancy. And what we know is there's significant disparities between different population groups. And one of the things we're interested in is why is it a care issue? Is it access to care? Are there other more fundamental processes and things we need to understand? When we work with international groups, again, we're working sometimes at the government level and sometimes with academic groups and sometimes with commercial groups. But we're also at the same time engaging with them to look at what may be unique differences that they have from the population groups we're looking at. You learn very early that, especially in biology, but in science in general, it's much more difficult to develop an understanding of an absolute concept than it is between two concepts, a concept or the applied differently in two different states. So understanding, I'll give you a specific example. We're looking at hypertensive disorders of pregnancy like preeclampsia. We're looking at hypertension in general, and we're looking at the fact that we don't address hypertension in terms of the true circadian pattern of blood pressure. But what we find when we start to look at that is Caucasian and African American populations have a significantly different pattern over circadian time or 24 hours. And we don't know what the significance of that may be in some of these other conditions. And so we're always looking and trying to build off of that and be very conscious of where things are similar or different and try to highlight those differences so they can be applied in it differentially, that we're not solving it for one population and not being able to translate it to be applied in other populations.
What excites you most about the future of healthcare analytics and IPQ's role in it?
Well, what we're trying to do is enhance transparency. So, it's interesting when I've gone into pharma to potentially do consults and we do this first stage that we were just talking about. By the time I leave, it's not uncommon for someone in the group to come up to me and say, we thought this was an easy problem, but you've made it very complicated. And what I always respond to that is, I actually didn't make it complicated. The biology makes it very complicated. You've just tried to reduce it to make it more simple, and that's why it's not actually working. And we don't have to identify all of the complexity. We don't have to solve everything. But the issue from our perspective is we want to drive to make it more transparent so then if something doesn't work in that reduced approach, we have some idea of why it may not work and what else to try. And we're not sitting there with a failure, but an opportunity to learn from that failure. And so where we fit in that equation is our ability to work from the clinical side, from the patient side, from the other perspectives in driving set of approaches to really identify what are the underlying real causal issues, not just the correlative issues that we're frequently coming up with when we're applying AI and ML methods. We really are interested in causality because causality is what's going to be critical to change medical practice.
Okay, well, final question. How can viewers or the audience find you online, or how can they contact you or reach out to you?
Well, they can Leibman at IPQanalytics.com or www.ipqanalytics.com. Our nonprofit, which we're in the process of finalizing registration, is probably going to be called Woven, but that's not up yet. That's in our other website. And I welcome the opportunity to interact with people and fill in the blanks for what we didn't discuss today.
Awesome. Well, that brings it close to the show. That was Designed to Thrive. Thank you, Michael, for hopping on. We'll see you next time.
Thank you.